CT and MR imaging of cardiac tumors. B. Zandi, Professor of Radiology. Objectives: to review the spectrum of CT and MRI findings for a variety of cardiac neoplasms. The role of CT and MRI in the diagnosis of cardiac tumors. To DD benign from malignant masses. The use of MDCT in providing anatomical information. MRI for tissue characterization of cardiac masses. Cardiac tumors prevalence of 0.002 to 0.3% at autopsy. 1. Primary cardiac neoplasms. Benign and malignant. 2. Metastatic. Approximately 30 times more prevalent than primary. Imaging modalities: transthoracic echocardiography, transesophageal echocardiography, multi-detector CT scanning, MDCT, magnetic resonance imaging, MRI. Imaging modalities: transthoracic echocardiography. Most widely used imaging modality. The best imaging modality to depict small masses, valves. Limitations: visualization of extracardiac extension. Less limitation of acoustic window than thoracic mode. The airways and lungs can be obstacles for imaging of the aortic arch, pulmonary arteries and veins. Imaging modalities: MRI. The modality of choice to evaluate cardiac tumors. High contrast resolution and MPR allow a specific diagnosis. Optimal evaluation of myocardial infiltration, pericardial involvement, and extracardiac extension. Imaging modalities: MDCT scan. MDCT recently has been increasingly utilized for cardiac imaging. Short image acquisition time compared to MRI, an advantage in cardiac imaging. ECG gating MDCT either by scanning or reconstructing raw data at the point of the least cardiac motion. CT has better soft tissue contrast resolution than echo. Definitively characterize fat and calcifications. Wide field of view helps to assess the extent of a cardiac malignancy and to detect metastatic lesions. Table 1. Primary benign tumors and cysts of heart and pericardium in 533 cases. Myxoma 130, 24.2. Lipoma 45, 8.4. Papillary fibroelastoma 42, 7.9. Rhabdomyoma 36, 6.8. Fibroma 17, 3.2. Hemangioma 15, 2.8. Teratoma 14, 2.6. Mesothelioma of Avenue node 12, 2.3. Granular cell tumor 3. Neurofibroma 3. Lymphangioma 3. Subtotal 319, 59.8. Pericardial cyst 82, 15.4. Bronchogenic cyst 7, 1.3. Subtotal 89, 16.7. Myxoma is the most common benign tumor, 4th-7th decades. Location: interatrial septum at fossa ovalis LA, most common. 75% LA, typically, in the interatrial septum. 20% in RA. Rarely in the ventricles. Typical morphologic characteristics: gelatinous, attached to stalk, calcification, hemorrhage or necrosis. Common imaging characteristics: echo features, mobile tumor, narrow stalk. CT features, well-defined spherical or ovoid intracavitary mass with heterogeneous, low attenuation, typically lobular contours. For CT, heterogeneous, hemorrhage, necrosis, cyst formation, fibrosis or calcification. MR imaging features: heterogeneous, before contrast. Heterogeneous enhancement, after contrast. Areas of low signal intensity within the tumor, due to calcification or hemosiderin. T2W, markedly high signal. MPR MDCT 4-chamber view. LV myxoma in 38-year-old female. A mass, arrow, in LA. B mass, arrow, extends into LV during diastolic phase through mitral valve. LA myxoma in 65-year-old male. MPRMDCT. LA myxoma in 65-year-old male. A shows LA mass attached to interatrial septum by broad pedicle. Strong enhancement in part of mass with foci of calcification. B gross specimen, multicolor soft tissue mass, mixture of hemorrhage, necrosis, cyst formation and fibrosis. RV myxoma in 30-year-old female. A iso-intense mass occupying root. MRI tear. MRI GD deer. MRI deer. RV myxoma in 30-year-old female. A iso-intense mass occupying root. B high signal intensity in most parts of mass. C hyperenhancement of mass. D yellow soft tissue mass with narrow base of attachment to RV. Short axis view systole. RV myxoma in a 55-year-old man. A mass prolapsing into the main PA. Lipoma is the second most common benign cardiac tumors in adults. Age, variable. Associated syndromes, tuberous sclerosis, few cases. Location, pericardial space or any cardiac chamber. Typical morphologic characteristics, very large, broad-based, no calcification, hemorrhage, or necrosis. Echo, usually hypoechoic in the pericardial space, echogenic in a cardiac chamber. Specific CT and MR imaging characteristics. CT, homogeneous, low attenuation mass. MRI, homogeneous high signal intensity on the T1/T2. That decreases with the use of fat set sequences. Do not show contrast enhancement. Array lipoma in 62-year-old female. ECG GMDCT. Array lipoma in 62-year-old female. A homogeneously low attenuated mass with pedicle, arrow, attached to free wall of RA. B gross specimen, shows fatty nature of mass. Intraoperative photograph. Apical 4CH view. T1W MR. Intraoperative photograph. Array lipoma in a 72-year-old man. A. Large mass, M, arising from the posterolateral wall of the RA. B. Circumscribed, broad-based mass, high signal fills most of the RA. C. Smooth lipoma filling the RA. 4CH, T2BP. T1BP. Delayed 10 minutes. Fat suppressed, T2. Lipomatous hypertrophy of the interatrial septum/35-year-old woman with AF. Sparing the adjacent fossa ovalis, favoring the diagnosis of lipomatous hypertrophy rather than lipoma. Fatty infiltration of the interatrial septum in a 69-year-old, mildly obese woman with palpitations, dyspnea, and an atrial tachyarrhythmia. Wedge-shaped fatty thickening of the interatrial septum, arrows. Extension of fatty tissue into the RV, arrowhead. Papillary fibroelastomas. Are benign endocardial papillomas. Age, middle age. Typical morphologic characteristics, small, less than 1.5 centimeters, frond-like, narrow stalk mass attached to the moving valves, calcification rare, no hemorrhage or necrosis. Location, cardiac valves. 75% of all cardiac valvular tumors. Echo, small masses with shimmering edges. CT and MR features, usually not seen. MRI, typically a mass on a valve leaflet or on the endocardial surface. Cine MR, turbulence in the blood flow. ECG gated MDCT. Cine MR. Oblique deer MR. Papillary fibroelastoma of our valve in 60-year-old female. A. Abnormal thickening of our valve, arrow. B. C. Small mass, arrows, attached to aortic valve, moving according to valvular motion. D. slightly high signal intensity of small mass, arrow. Rhabdomyomas, the most common cardiac tumors in infancy and childhood. Associated syndromes, tuberous sclerosis in up to 50% of cases. Mostly asymptomatic and generally regress spontaneously. Location, typically in the myocardium of ventricles, and multiple lesions up to 90% of cases. MRI. T1W, isointense to marginally hyperintense. T2W, hyperintense. Cardiac rhabdomyoma in newborn with tuberous sclerosis. GDE T1W. Sagittal T1W SE Mr. Axial GDE T1W SE Mr. Cardiac rhabdomyoma in newborn with tuberous sclerosis. A. Nodules in caudate nuclei and frontal lobes. B. Isointense mass in septum and anterior wall of LV. C. Mild enhancement. T1 T2 SSFP, WB, delayed 10 min. Fibroma of the LV in a 32-year-old F, with recurrent syncope and runs of VTAC. A, B, C, a well-defined, low-signal mass within the anterior wall of the LV. D, uniform enhancement and a thin rim of surrounding compressed myocardium. Table 1. Primary malignant tumors and cysts of heart and pericardium in 533 cases. Angiosarcoma 39, 7.3. Rhabdomyosarcoma 26, 4.9. Mesothelioma 19, 3.6. Fibrosarcoma 14, 2.6. Malignant lymphoma 7, 1.3. Extraskeletal osteosarcoma 5. Neurogenic sarcoma 4. Malignant teratoma 1. Thymoma 1. Leiomyosarcoma 1. Liposarcoma synovial sarcoma 1. Subtotal 125, 23.5. Angiosarcomas, the most common cardiac sarcomas, 37%. Location, RA and involves the pericardium. Presentation, right-sided heart failure or tamponade. Late presentation, often metastases at the time of diagnosis, particularly to the lung. Invasive behavior, pericardial or pleural effusion. Angiosarcomas CT, a low-density irregular or nodular mass in the RA. Specific MR feature, on T1/T2, a heterogeneous papillary appearance, within nodular areas of high signal interspersed within areas of intermediate signal. Enhancement, linear along the vascular spaces as a sunray. ECG gated MDCT Dear Mr. GDE Dear Mr. Angiosarcoma of RA in 48-year-old male. A. Large mass at the free wall of RA. Irregular and nodular contour and strong contrast enhancement. B. Mostly isointense mass in RA. C. Heterogeneously hyperintense mass. D. Heterogeneous hyperenhancement / areas of no enhancement, intratumoral thrombosis. T2W Dear FSE. T1W Dear FSE. 4CHSSFP. T1W Dear FSE. Primary cardiac angiosarcoma in a 55-year-old man with weight loss, dyspnea, and peripheral edema. A large, heterogeneous, isointense mass completely obliterates the RA. Areas of low and high signal, due to hemorrhage, necrosis. The influence of different MR sequences. Primary cardiac angiosarcoma. T1 Zecoplanar. T2W Dear Fast SE. T2W Dear Fat Sup. Primary cardiac angiosarcoma in a 25-year-old woman. With leg swelling, abdominal pain, bloating, and dyspnea. A large heterogeneous mass at the RA free wall. Predominantly isointense, some areas of high signal, localized hemorrhage. B. C. Large, hyperintense, water-rich mass, left PNLF. Other cardiac sarcomas, including undifferentiated sarcomas, Malignant fibrous histiocytomas, MFHs. Leiomyosarcomas. Osteosarcomas. Lymphosarcomas. Myxosarcomas. Neurogenic sarcomas. Synovial sarcomas. Neurofibrosarcomas. Kaposi's sarcomas. Although most angiosarcomas occur in the RA, the other sarcomas affect the LA more frequently, an important differentiating feature. Rhabdomyosarcoma is the commonest childhood primary cardiac malignancy. Two distinct histological types. Embryonal types occur in children and adults. Pleomorphic, much less frequent and occur in adulthood. Location, no specific chamber. Valves involvement is more likely than any other primary cardiac sarcoma. Multiple sites of involvement. Rhabdomyosarcoma. The presentation depends on the area of involvement. But as the other cardiac sarcomas, CHF is common. MRI. T1W isointense to myocardium. Homogeneous GD enhancement. Some areas of low signal intensity, central necrosis. T1SE 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 rhabdomyosarcoma in 22-year-old. MDCT plus 4. T1SE. 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 Rhabdomyosarcoma in 22-year-old. A. DMDCT plus 4. LA mass extending through the septum to the RA. B. C. T1SE 6 months after resection, recurrence at the septum and pericardial involvement, fibrosarcoma. Court 4 chamber involvement. D1W 1 year later after therapy. Primary cardiac lymphomas. Extremely rare, incidence of 0.15 to 1%. Most common type, diffuse large B-cell. Mostly, solid infiltrative tumors in one or multiple chambers of the heart. Mimicking classic HCM, massive infiltration of the myocardium. Primary cardiac lymphomas. CT. As hypo or iso-attenuated infiltration. Enhancement, heterogeneous. MRI. T1W, iso-intense. T2W, heterogeneously hyperintense. GDE, heterogeneous enhancement, NMDCT. GDE Dear Mr. Primary cardiac lymphoma, diffuse large B-cell type, in 73-year-old male. A homogeneous infiltration at RA wall and interatrial septum. Pericardial effusion, pericardial invasion. B. Diffuse infiltrative mass in RA. Homogeneous enhancement, distinguishes it from pericardial F. Primary cardiac lymphoma, different patterns of cardiac involvement. SSFP, WB. T1BB. A 35-year-old man with AIDS presented with dyspnea. A large, solid mass filling the LAI so intense with myocardium. B. A 42-year-old F, no history of immunosuppression / with cardiac failure. Diffuse soft tissue mass filling the pericardial space and the free wall of the RA and LV. Secondary cardiac lymphoma, bilateral adrenal, renal and intra- and retroperitoneal involvement. Metastatic involvement. Much more common than primary tumors, ratio of 30:1. Cardiac mets occur in 11% of cases of malignancies. Most frequent malignancies to the heart, lung, breast, melanomas, and lymphomas. The most common site, epicardium. Spreading means 1. Mainly the mediastinal lymphatics to the epicardial surface. 2. Hematogenously through the coronary arteries, or less commonly IVC. 3. Direct extension, thymic, bronchial, breast and esophagus. Metastatic involvement. Commonly coincidence hematogenous mets in other organs, lungs. Transvenous tumor spread into the RA through the SVC, lung, or IVC, kidney or liver. into the LA via the pulmonary veins. DD of metastases from thrombus. Enhancement patterns after 4-GDE, heterogeneous N. IR time 400-500 msec. Intracardiac metastases, 20-year-old, seminoma, with dyspnea and chest pain. MDCT, several large low attenuation masses within the RV. The changes in both lungs, caused by multiple tumor emboli. Hematogenous cardiac metastases from HCC. MDCT. GDE Dear Mr. Arterial, C, and delayed, D, CT. Hematogenous cardiac metastases from HCC. A, B, marked diffuse thickening of RV free wall, arrows. C, DHCC characteristic pattern of early enhancement and washout. Direct venous extension of a left-sided RCC. Non-enhanced T1 WSE echoplanar. Direct venous extension of a left-sided RCC. LRV and IVC are filled by a iso-intense mass extending into the RA. Tumor-like lesions. Thrombus is the commonest mimic of a cardiac neoplasms. Most likely to be located posteriorly in the LA, AF, or severe LV dysfunction. It can also be found in the right side of the heart. Tumor-like lesions, thrombus. Mr. Characteristics, variable depending on the age of the thrombus. Acute thrombus, bright on both T1 and T2. Subacute thrombus, bright on T1, and low signal areas on T2, the paramagnetic effects of methemoglobin. Chronic organized thrombus, T1/T2, low signal, water depletion, with or without calcification. GDE, useful for DD thrombus from tumors, thrombus doesn't enhance. Long inversion time, 400 msec. Note, organized thrombus may show some surface enhancement. DD, slow or static flow, flows through the imaging plane, intracardiac thrombus. Vertical, long axis, 2ch, delayed 10 minutes, long IR time 500 ms. Intracardiac thrombus. A 64-year-old man with a past history of anterior wall myocardial infarction. Non-enhanced mass, arrows, and an overlying, high signal, full thickness ME. B, a 55-year-old man with a prior history of anterior myocardial infarction. A low attenuation mass within the LV. Delayed 10 minutes plus 500 msec IR. SSFP. Flow artifact within the RV is a low attenuation filling defect pseudotumor IVC inflow, thrombus different locations. A smoothly marginated mass indenting the RV free wall. Axial SSFP. Coronal GDE first pass. RCA aneurysm. A smoothly marginated mass indenting the RV free wall.